Welcome to part 2 of our flipped classroom learning. This section will talk about flexibility and stretching. We're going to cover all of Kisner chapter 4 and portions of chapter 10, especially where it's related to soft tissue and connective tissue flexibility. So what is flexibility? The ability to move a joint or a series of joints smoothly and easily through an unrestricted range of motion. So really we're looking at functional ability to move and quality of movement. What determines that looks much like range of motion. Again, muscle length, so something extra-articular, the integrity of the joint, and that includes the structures around the joint. And now we add in neuromuscular control. What causes limited mobility? So we have three main types: injury, immobilization, and disuse. In injury, we can have an acute traumatic overload, or we can have what's called a repetitive overload or a microtrauma. If the tissue is healthy, but you beat it up over time with lots of load, you can have injury. Sometimes the tissue isn't quite healthy and you have normal loading that causes injury. Immobilization might be an external device, like you see here with someone who fractured their humerus and is put in a splint. You might have internal causes, meaning within the body itself, so pain or swelling, muscle, tendon, or joint disorder. You might have a bony block, something might be going on in the skin. And disuse might just be because of habit. It could be something more neurologic or another disease process. Some definitions that you should know. Tendinosis is probably one that I'd like you to focus on. It's a degenerative tendon condition, and so those are the folks that we are seeing in our clinics 3 and 4 months after an injury, and they still are having signs that look like a tendinitis, but really the inflammatory process has quieted. And here's the classic kind of weekend warrior. So they have a chronic situation and then they have these recurrent overloads. So they're having repeated tissue injury. And that is really our bread and butter. And when we think about diagnosis and management of patients, this is where our skills at looking not just at what specific complaint the patient has, but looking across the spectrum of their whole movement, like you did with the specific functional movement assessment, looking at the kinematic chain helps to restore function. So a review, hopefully, see table 10.1 in Kisner and Colby related to soft tissue healing. What I'd like you to pick up from this is certainly the elements that are involved in each phase of healing, but most importantly, what's our management goal? So in the acute phase, it's that first, few hours to a few days. Your book says 0 to 6 days. Our key is protection. So we really want to not put too much stress on that healing tissue so that the cells can be laid down and the best type of tissue can be recovered. In the subacute phase, which goes from 1 week to several weeks, the tissue is repairing, new collagen is being laid down, the fibroblast activity increases, so the scar shrinks, the wound closes. That's all good. That's our time where we start doing a little bit more activity with the patient, and the key is graduated loading. The challenge, there's no specific protocol. So we really need to be in communication with our patients at this point as we start doing stretching and or active motion or even strengthening exercises to look for those adverse responses like pain and inflammation. And in the chronic functional phase, which is your book's term for the patient who's towards the end stage, look at the timeline, 3 weeks to several years. So it depends upon the tissue. Some heal faster, some heal a little bit slower when that phase is entered. And our goal or our task is maturation and remodeling. So we really want to be doing functional loading. And you can read the details of what that cellular response is. Here's the stress strain curve. So every tissue, every material has a stress strain curve, and all it really talks about is how much load do I need to apply to deform or lengthen, in this case, because we're talking about stretching the tissue, or bending, sometimes bending stress. So we have this toe region, and this is a region where I don't really need to add much load and I can have elongation. In physical therapy, we call this the neutral zone. For techniques, this is where we do range of motion. I don't need a lot of load. I'm getting movement, but I'm not really getting a lot of strain or lengthening. In the elastic region, there's a pretty consistent one-to-one or set relationship between how much stress I apply and how much deformation or strain or length I get. We call that the elastic zone because that's usually recoverable tissue deformation. So this would be doing range of motion, perhaps getting an end feel. We're not changing the length of that tissue, we're just taking it up to the end. The plastic range here, and the shape of this curve can vary quite a bit based on the tissue. It's where I actually am lengthening the tissue. So this is where we want to actually make the connective tissue cell or the overall tissue longer. And that's what we do with stretching. What we don't want to do is get over in this range where we have failure. The necking region is where I start to get tissue elongation without much additional load or with less additional load. So you can already feel that where the tissue's starting to give. So think about saran wrap. When you start to pull it, it gives. It always is in this plastic region, but when I really start to deform before it tears a hole, tearing a hole is the failure, this necking region where it really starts to give is the necking region. Some terms to be aware of: hypo and hypermobility. Hypo means not enough or adaptive shortening. Hyper is excessive. Hypermobility, you can have excess motion and be normal and functional. So to distinguish hypermobility from instability is key. So instability is a hypermobility that impacts function. Stretching, I want you to be aware that stretching does not equal range of motion. Very often they're put together clinically, but the principles and the purpose are different. And then a contracture. A contracture is an adaptive shortening of the soft tissue structures around a joint that result in a limitation of motion. So if I have a knee flexion contracture, that means my knee flexion side of the joint is limited and I don't have knee extension. A little bit of neurophysiology, hopefully review that you've heard about Golgi tendon organs and muscle spindles. So when I put tension along a musculotendinous structure, my muscle spindles will note a change in the length of the muscle as well as the velocity of that change. The Golgi tendon organs, which sit more in the tendinous structure, note a change in tension. So when I stretch this, what is the response back into the nervous system and then the motor response out? So when I stretch a tendon or a muscle, my muscle spindle is going to send a signal out. It's going to be active, noting that I've put tension. I've changed the length of the muscle spindle, and it'll note how fast or slow I did that. And it's going to send information into the spinal cord and out via the alpha motor neuron stretch reflex to facilitate increased tension in the muscle. So stretching the muscle spindle facilitates that same muscle to contract. And it's that reflex arc that we're testing when we do muscle reflex testing. The Golgi tendon organ, on the other hand, senses a change in tension, and it puts a signal into the central nervous system and has a signal out, an efferent response that inhibits that same muscle from being stretched. So they kind of fight one another. Our muscle spindles activate, our GTOs inhibit. Connective tissue. I understand that you've heard this before, so this will be a brief review. We have lots of different types of collagen. We're mostly focused on 3 types. So type 1 are tension loading, ligaments, tendons, the annulus, and the disc. Type 2 does compression loading, so nucleus, it's the ground substance of articular cartilage or hyaline cartilage. Type 3 is where we really have scar tissue formation. It's not as organized. It doesn't have the same stress strain characteristics. It doesn't have the same load tolerance of the tissue around it. So it's kind of the weak link, and where that scar tissue connects to the normal tissue often can be a region of further stress. We also have elastin, which gives flexibility in our tissue, ligamentum flavum in the spinal canal. So if you haven't opened the spines yet and looked at that, please do, because it's a very unique looking ligament. And reticulin, which give the tissue bulk. And finally, ground substance. Ground substance, I'm not sure how much you've studied, but ground substance is the stuff surrounding the collagen fibers. So it's a glycoprotein and proteoglycans. It really is what helps give the tissue hydration. It is very hydrophilic, meaning it likes to imbibe water. It helps to stabilize the collagen network, and it's really that helps to give that resistance to compression. The amount of it varies in terms of the tissue and the amount of collagen. The ratio will vary depending on the tissue and the type of demands on the tissue, but we need ground substance in order to keep our tissues healthy. The collagen that's located in tendon, ligament, and skin looks a little bit differently. All of them are made up of tropocollagen as the building block, but the arrangement of those fascicles of tendon or fascicles of collagen look different in a tendon, where you see this more parallel arrangement. Ligaments that are parallel and oblique, and skin, which really has a random arrangement. So tendon is more like your denim, ligament is like a stretchy lycra fabric, and skin really is more like felt, where there's really not a lot of tolerance to deformation. It's very elastic and it gives. And when you think about the function of tendons usually are connecting a muscle to a bone, and the stress, the pull through the tendon is fairly uniform. Whereas a ligament, take the medial collateral ligament, it's a very broad ligament in the knee. It has to withstand that frontal plane stresses as well as horizontal or transverse plane, the rotatory force. So it's good that our ligaments have parallel and oblique orientations. So why should I stretch? Well, these are pretty obvious. Adhesions, contractures, scar tissue when I have limited range of motion. When that movement restricts other things, or the limitation may lead to further problems. So think about your student's posture and the impact it's having on necks and shoulders. So some stretching of the anterior chest probably is a good way to end the day. Weakness of opposing muscles. So if you get tight in one muscle, it's very hard to get activity through the full range in the other muscle. And a lot of times stretching is included in a fitness program as either a warm-up or cool down. What we know about stretching, however, is it decreases muscle quality of performance. So active warm-up versus a passive static stretching warm-up is now recommended, and probably most of you have had that type of instruction. Stretching also does not decrease post-exercise soreness. However, it's a routine many people get into, and so you have to probe that as you start to work with patients and decide what you need to do in terms of a home program. Why should you not stretch? Bony block that limits motion. So if you've had a greater tuberosity fracture or greater tubercle fracture in the humerus, often you're going to have a limitation of elevation or perhaps shoulder external rotation. We're not going to move the bone by stretching it. We're just going to create more problems. If they had a recent fracture and the bone isn't fully healed, so they've undergone primary healing versus secondary healing, or the healing is just not taking place. Acute inflammation or infection, make sure that that's well managed. Sharp acute pain with movement, especially if you don't know why they might be having that sharp pain. If they have an acute hematoma or tissue trauma, that's that heterotopic ossification risk that you saw in the previous slide set. Hypermobility, again, hypermobility is not a pathology. Instability is where we are worried because it's impacting function. But hypermobility should be something that you pay attention to. And then especially when I need that functional shortness of the tissues in order to function. So tenodesis, if you put your arm out and you keep your fingers relaxed but just extend your wrist, you should notice that your fingers automatically close. That's called a tenodesis grip. And for someone who is a quadriplegic or paraplegic that has limited perhaps hand function, that tenodesis grip, so letting some stiffness happen to the finger flexors, would be important. Also, long sitting in someone who has had a spinal cord injury and they're a paraplegia. Hamstring tension, you need enough tension so they can long sit, but not so much that they're going to fall over. So that's a situation, they're fairly specialized situations, but where you might not want to do stretching. Precautions, someone with osteoporosis, and you don't always know if a patient has osteoporosis, you might need to ask. Subacute fractures, meaning fractures that are healing or maybe a bone bruise if they've recently been immobilized. Edema, muscles that are weak so you can't really work against gravity. Pain if they're using corticosteroids, and think about your people with asthma or a lot of allergies, sometimes the steroid dose pack is given. And then as we get more experienced in life, we tend to get stiffer. And that's adaptation sometimes, not just stiffness in the musculoligamentous or connective tissues around the joints. So when we do stretching, we need to give it a dose. So what are my parameters for stretching? I need to know what motion I'm going to do, what position, what intensity, what duration, what's my velocity, slow or fast, what mode am I going to do it self, is there a machine, am I going to do manual stretching, how often should I do that, once a day, once a week, once a month, and how many repetitions. Now this lady here doesn't obviously need to do probably much stretching, maybe some stability training. So here's a picture of a gentleman doing a stretch. We assume they're doing a quad stretch. And one picture looks, in my opinion, a little bit better than the other. So is this picture to the left, picture A, doing a better job of stretching the quadriceps, or picture B? Well, if you say just the vasti group, either one will do. But if we think about rectus femoris, which is part of the quadriceps muscle, then I would have to go with picture A, because my proximal attachment is stabilized because the pelvis has stayed stable. Here, I've brought my distal attachment towards my proximal attachment, so I'm really not getting a full or effective stretch. So that's what we talk about by stabilizing one partner. The position, gravity assisted, is best. So this shows a person working on knee flexion, sliding down the wall. If you can't get in a gravity assisted position, then gravity neutral. It's much harder to stretch against gravity, although you'll see it done. Here's someone doing a manual stretch for the hip flexor versus a self stretch. And really the distinction your book makes, which may or may not hold true, is that in a manual stretch, I'm moving the distal segment and stabilizing proximally. When the patient does it, they stabilize distally and move proximally. So this is a left hip flexor stretch in both cases. How about intensity? So I need enough load so that the tissues elongate. And you say, well, how much is that? So if you take your index finger on your hand and you pull your finger back as far as it can go into extension or hyperextension in this case, you should feel something on the MCP joint of your hand. And you want to feel it, but you shouldn't be gritting your teeth or weeping because the pain is so intense. And so if patient has intact sensation, that can be a nice guide to help them to know how much load. If you don't feel it, you're probably not giving it a sufficient load. Okay, so I need to make sure the patient's comfortable, that they're not guarding because they're working so hard, because that would mean perhaps they've given it an overload. High intensity load, so that's more fast or ballistic type stretching, is really done primarily in highly trained athletes and at the much later stages. So it's not something you're going to see much in the clinic. When I look at stretching duration, we have a couple of concepts that we need to consider. So we have creep and stress relaxation. Creep looks at change in length based on time. And so this graph shows that the longer I hold a stretch, the more tissue deformation I get without changing the load. That's what we want with our stretching. We want plastic deformation. Stress relaxation, I'd like you to experience that. So as I'm talking at you, I want you to either stand up, bend over and touch your toes and just keep holding that until I'll give you a cue to stop at some point. Not too long, so it's okay. Or you can sit up nice and tall and extend your leg and keep your ankle dorsiflexed. So stress relaxation looks at the internal tissue stiffness. Keep bending over, keep your legs straight, based on what happens over time. So with constant positioning, the internal tension of the structure should decrease in time. So now take a sense of what's going on in your, if you bent over or if you're sitting with your legs straight, and go ahead and relax. What you should have noticed is you felt it when you started, And once I told you to let go, you shouldn't have been feeling it anymore. So why is that? Well, that's stress relaxation. So how long do I really need to hold a stretch? The longer the duration, the better plastic deformation, but a shorter duration is really more comfortable and convenient for the patient. So we want to use a duration that produces that optimal connective tissue plasticity that minimizes stretch reflex activation because that would cause a muscle to tighten up. And we also want to enhance GTO activation. So research studies tell us that a midline duration of 15 to 30 seconds gets part of a majority of the plastic deformation ability of connective tissue. You need to hold it for about 2 minutes to get 100% of that. So how fast do I hold a stretch? So the speed, slow speed, I get greater compliance because of viscoelastic properties. So if you've ever mixed cornstarch and water together, and then you have to work kind of hard to get the water in there, and then you tap it really hard, that's very firm and rigid. But if you just lay your finger on top of it, it starts to sink in. So that's viscous and elastic properties, viscoelastic properties put together, and that's what's in our body. Slow administered stretch again minimizes stretch reflex activation, and so we're going to know when we need to stop. You'll have less tissue trauma. But in the later stages, as we heard with athletes, they'll perhaps engage in high velocity or high speed stretching. A little review about intensity, duration, and velocity, static stretching, cyclic on-off, or ballistic kind of bouncing type stretching. The mode, you can have an external device that causes the stretching. You can have a mechanical device, and we'll hear that about continuous passive motion machines. They can also do a little bit of stretching. You can also do self-stretching or active stretching. So how much do I need to do? How frequently? Well, to maintain range of motion, you only need to do one motion a day. But to increase motion, we need to do more than that. So I need to know how much of a single stretch per unit of time, a low frequency, long duration, or a high frequency, short duration to get that 30 seconds to 2 minutes. How many of those packets do I need to really get elongation? And the more range of motion I need, the more stretching I should be doing. If we look at the dose or the amount, if I look at the on time or the stretching time, the number of stretches times the duration that I held the stretch really is my dose. So if I do a stretch I do 4 stretches holding them for 15 seconds, and then I do 3 sets of that, that would be the same stretching dose as a 1-minute stretch repeated 3 times. So you have to pick the parameters of how much and how often based on what your patient can tolerate and what you're stretching. And then I would need to add the piece that's missing here is how frequently am I doing that? Once a day, twice a day, once a week? Once a week is probably not sufficient to get true length in a muscle. So we need to add that piece is missing. And certainly when we do stretching, we want to add a warm up to the tissues because the connective tissue will be more flexible. We heard that with ultrasound and with heating. That's one of the benefits. So we can do our superficial heat. We can also warm up with exercise. We can do some active exercise called PNF. You've heard or are exposed to the patterns in Intro to Patient Management. The techniques, hold, relax, agonist contraction. HR's hold, relax with agonist contraction is kind of a combination. So hold, relax says I'm going to activate the antagonist. So if I am stretching my hamstring, I'm going to activate my quadriceps to inhibit my hamstring, or my hip flexor to inhibit the hamstring that works at the hip. That's called reciprocal inhibition. And I can also do that by contracting the agonist, or that muscle that I'm interested in. So if I'm stretching the hamstrings, I'm going to activate the hamstrings and then relax the hamstrings to inhibit the hamstring. I can also do just active stretching, and that would be specific, or you can do general kind of patterns of stretching. So let's talk about Joe. Joe's a 27-year-old male. We heard about him in the range of motion lecture. He's now 1 week out from his TBI. He's still not ambulatory, but he looks like at least a little bit more alert. He has the head of the bed still at 30 degrees because of the swelling. Got just a little bit of swelling going on there. What we notice now is he has a loss of hamstring flexibility, meaning his straight leg raise. If I lay the patient supine as he can get, keep the knee straight and lift the leg up, the angle between the bed and the leg is 50 degrees. And you're going to find that the normal, supposedly, is 90. What would I do to stretch to gain flexibility, hamstring flexibility for Joe? So I want you to pause the video and write down how much, so what are we stretching? We're stretching the hamstrings. What position? What motion? How much? How long? How frequent? Is it going to be something Joe does to himself? Is it something you, the therapist, do? Is it something that he can do actively? Okay, so what did you come up with? Hopefully you did some type of stretch that allowed him to move, to lengthen his hamstrings. So the hamstrings come from the ischial tuberosity and they cross the knee joint down to the tendon. So I need to flex the hip and extend the knee. And we'll show you 2 different types of muscle length testing for the hamstring, and either would be appropriate. If Joe is doing this to himself, I would have him bring his knee towards his chest and grasp underneath his thigh if he can be cooperative and understand that. And then I would have him try to lift his foot to the ceiling while he keeps his hands grasped around his thigh to try to get the tibia to go all the way, or the foot all the way to the ceiling. And I would have him hold that for a count of 15. Then I would have him bend his knee. I would have him lift it up again and hold for a count of 15. And I would have him do 8 to 10 of those, and I would have him try to do it around mealtime. So he's doing 8 repetitions holding for 15 seconds. That gets about a 2-minute dose. And he's doing that 8 to 15 repetitions 3 times a day. What about Florence? So she's a 76-year-old female who had a terrible looking knee. Here's one that has osteoarthritis. And then she had a total knee arthroplasty. She's 3 weeks out. Her active motion is 5 to 95 degrees. So 5 degrees is extension, 95 is flexion. Normal is 0 to 135. Her passive range of motion, you could see she's still limited in extension. She has a little bit more flexion passively. Quad strength is 3 out of 5. Normal is 5. So she has the ability to move her tibia against gravity. So her quadriceps is a fair grade strength. But she's got some inhibition because of pain in the joint. Her pain is a 2 out of 10. So what would you do to stretch Florence, who's 3 weeks post total knee arthroplasty? So she's got a fairly nice open incision. It's not perfectly healed yet at 3 weeks out, along from her tibial tuberosity really up past her suprapatellar pouch. So because Florence has only 95 or 100 degrees of flexion and we're trying to get flexion range of motion, we might do a sitting stretch with Florence where she's perhaps sitting on a chair, sitting at the edge of the bed, and we call it the sit and scoot stretch. And you're going to try that in lab. And we would have her hold that, bend her knee as far underneath her as she can while she's sitting in the chair. So hold it until she doesn't feel it anymore, 30 seconds to a minute. And then keeping her feet in place, scoot her fanny forward on the chair so she feels it again. And we'll have her work for about 5 minutes of stretching and do that 3 times a day. We also need to work on the extension. So I'm going to have Florence lay down in bed and prop her heel on a pillow and try to just let her leg relax or her quadriceps relax into that extension stretch. And I'll have her stay there because it's hard to get in and out of that position for 2 minutes. And then take a little break and then do 2 minutes of that again. And again, we'll have her try to get to 3 times a day with that activity. So that ends our discussion on stretching and flexibility.